Top Med Talk.
Nick Geriatric here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Professor Imogen Mitchell. Professor Mitchell is the Dean of the Australian National University Medical School and Senior Staff Specialist in Intensive Care at the Canberra Hospital. She was previously a Senior Medical Advisor at the Australian Commission on Safety and Quality in Healthcare. During this appointment, she was able to undertake large multi-center study on the dying process in patients and evaluate the perceptions of dying by healthcare professionals. These data will help inform hospitals on where to improve end-of-life care, both locally and nationally. Professor Mitchell has also overseen the implementation of a rigorous hospital-wide clinical review process and a patient deterioration system. Prof. Mitchell was awarded a Harkness Fellowship in 2013 and 14 at Johns Hopkins Bloomberg School of Public Health, studying health systems and health policy. She'll be delivering a talk on how do we minimize failure to rescue in the post-operative period. Thank you very much, Professor Mitchell.
Thank you very much, and many thanks to the organiser, particularly Jill Van Acker, for inviting me here. We're all slightly nervous when you're an intensive care doctor surrounded by other types of disciplines, not least the anaesthetists. Right, so it's my job to try and help you understand what I see might be minimisation of, the deteriorating patient and rescuing them on the wards once they are discharged from the safe hands of the anaesthetist. Now, the last time I spoke in Melbourne, I was sitting in the audience, and it was only just at that point I decided I'd look at the title of the talk that I was giving and was slightly horrified that I'd actually got the wrong talk for that session. So I'm hoping today I've actually got the right talk for the right session. And in thinking about what I might talk about, as a non-anaesthetist, so I'm a physician by training, I'm thinking, well, let's think about this logically. So I'm going to try and set the scene of a deteriorating patient, and then how might I think about reducing the failure of patients post-anaesthetic and surgery, and obviously asking a few questions beforehand, during, and then afterwards, and then how might we rescue those patients, both through a ward system but also an intensive care system. And what do we see is the next steps of really trying to create a safe environment for our patients. So if we just go back to think, well, what are we talking about when we talk about a deteriorating patient? And in trying to write a series of talks on medical students at least a decade ago, I was trying to think, well, what does a deteriorating patient really mean? What I think it means is that it is a patient who's at risk of critical illness, and critical illness in my own eyes, and not everyone's eyes, is the fact that you're not probably going to get enough oxygen to the tissues, and they've got inadequate function of those organs. We've just heard about the kidneys, and that's but one organ that might suffer as a result of inadequate oxygen getting to the tissues. So anything that happens, both preoperatively to your heart, your lungs, may actually then impact and put you at higher risk of being a deteriorating patient. And then anything that you do during the operation, whether that's massive blood transfusion or fluids or mucking around with the cardiac output, then presumably that is going to put the patient at further risk. So if you think about that as a sort of the key to the deteriorating patient, what are the elements that you can try and prevent that then might occur on the ward if you don't get onto it quickly? Because if you don't get onto it quickly, these patients will be at increase of death. So in my own organisation, I've just looked at the last 2 years of our medical emergency team reviews. So nearly 4,000 calls for, I think, about 65,000 separations each year. So that's 2,000 a year Met calls. And a quarter of those will get transferred to the intensive care unit. So many of my intensive care colleagues will be grumbling that they never trained to do medical registrar management on the wards because only a quarter of these patients then go to intensive care unit. A very small proportion, it seems, I'm going to have to check these data, seem to be under the care of a surgeon when we go out to the wards for these MET calls. So quite a small minority are getting worse following or under the care of a surgeon. I'm not sure what that says. But then if we look at the patients who deteriorate immediately after being discharged from the recovery area, it's only about 5% of the MET calls. But of those, significantly, a third will go back to the intensive care unit, and there's an 8% mortality. Now, I haven't teased out the difference between emergency and elective, but it's still a reasonable workload, and maybe we could look at how we might prevent those MET calls happening post-operatively, well, within the first 24 hours, when you may have actually done something differently in the recovery area to try and prevent those MET calls. So then we look at the types of call-outs that we get, and the main symptom is hypotension. And again, I'm having this debate with the anaesthetist, is when you're using drugs such as metaraminol and just switch them off, and then because everything's looking great just for that 1 hour, and then they go to the ward and then they don't look quite so good. So is there a time frame when either they need to go to a higher dependency area, or can we just wait a little longer in the recovery area? So these are the sorts of calls that we will get. Whether we can prevent them, I don't know. So how then do we actually prevent these patients from deteriorating? I've talked a bit about how we need to sustain oxygen delivery, and that's all very well in sort of scientific terms, but how do we actually look at them when we're faced with them face to face? Well, the first thing, of course, if you're going to, really reduce the risk of patients deteriorating after surgery, is actually not to operate on them at all. And that obviously is a question for both the surgeon and the anaesthetist, and some people will involve the intensive care specialists as well. But how do we also detect those that are going to be at risk of cardiovascular instability or respiratory function or anything that will threaten the oxygen going to the tissues? Well, there are many tools to, triage the patient to look at the risk. And as I said, I do think the question, and I got raised a couple of days ago, and I'm sure throughout, is, we really have to think long and hard, is the surgery that you're about to undertake going to be actually of benefit to the patient in the long term? Because often what we do is we look at the patient in front of us, and it's very easy to do something than not to do something. And if you do something, then have a very clear goals of care pathway afterwards. Too often do I feel like get called into recovery or to the ward area where the patient has had a fractured neck of femur operation, everything's gone very successfully until it hasn't. And yet you're now faced with a patient with multiple comorbidities who really was not going to have a brilliant quality of life thereafter, and there was not a clear plan in the notes to work out what we're going to do next. So that's the first question. And then, of course, if you're looking at your patient at risk, are you going to be doing just local anaesthesia, or are you going to be doing general anaesthesia? And there in themselves will have risks as well. Will you therefore need some invasive monitoring, and do you need to think about when the patient needs intensive care or a higher dependency care? But it is really all about making sure that your patient is safe and that they have the best experience possible. And only just yesterday in the BMJ, when we're looking at decision-making for places like intensive care, I really do think we need to think long and hard, is it actually going to benefit the patient in the long term? And I think sometimes we don't think about this enough. And then when we're looking at trying to triage our patients in terms of risk, there are multiple triage tools, and you can see just by the number, there's obviously not one system that's really working for everyone. So there's multiple sort of types of systems. So there is no ideal risk stratification tool, unless I may have misread the literature. And of course, there's not only the risk stratification, but it's also what you do during the theatre and the operation, and subsequently that will also impact the risk upon the patient. And these tools may be too sensitive or not specific enough. And so these are challenges that we face every day. And when you're making a decision, is the patient high risk or not at high risk? But we at least need to be thinking about it, which I'm sure everyone does. Now, when you're just looking at who's going to be more likely a risk, you need to look at the types of surgery and the comorbidity, which you're all going to be very aware of. But clearly, these patients will somehow be threatening their oxygen delivery in one way or another, whether it's the operation, the comorbidity previously. But you need to think about these patients and how you might protect them in terms of maintaining oxygen delivery. And then, of course, if you have high-risk patients, they are going to do worse. So Rupert Pearce in the UK has obviously done a lot of work in the preoperative or perioperative arena and looked at the high-risk surgical patients according to the surgery that they got. So any DRG that was over the 5% mortality, then he grouped them up and found that they have a significant mortality, over 12%, and also the fact that they have a longer hospital stay. So we talked about high-cost patients. These are certainly going to be high-cost patients, both in experience and in terms of length of stay. Of course, there are guidelines. We talked about guidelines just earlier, and you'll all be familiar with the ACI, who've done a very nice sort of compact look at how we might manage our patients going through the perioperative area and looking at risk stratification of making us aware of who's at risk and who's not at risk. Those that are at risk obviously depends on the surgery that you're going to be undertaking, but also we've heard about from Bobby Jean the functional status as well of the patient, and how much intervention you're going to be doing during the surgery, the amount of fluid that you'll be giving, but also what are the risks of the patient undergoing a major adverse cardiac event. And then you can go and decide whether these are patients are high risk or low risk, and then that really will dictate whether you're more likely to ask for a high dependency bed or not. And often it's the patients who are routinely admitted to the intensive care or high dependency area with these major surgical procedures, and it's the ones that are not put in that category that perhaps should have been through comorbidities or what you've done during surgery. Maybe they should also be coming as well, but of course there's always the bed crisis. So if we try and work out who is at risk pre-operatively, to the fact that they may suffer cardiovascular complications or respiratory complications, then maybe the next step is, well, we've got to work out who's going to be at risk once they get into the recovery area if they're not already booked to go to a critical care area. So the key here is, when do you discharge your patient and they're ready for the ward? It seems to me that there is no one tool, again, that will help you understand which patient definitely needs better support. But whichever tool you use, it is likely to include, you've got to look at their conscious state and their blood pressure, whether the pain has been adequately managed or not, and that you have actually controlled their nausea and vomiting, I would imagine, before you actually discharge the patient to the ward. And then there may be other vital signs that you might want to consider. But certainly blood pressure, as I've alluded to previously, was a trigger for a METCOR post our recovery patients, and indeed conscious level was there as well. So these are certainly markers of thinking about what you may just want to hold back or send into a critical care area. But if you're then saying, well, okay, you've now just said they're fit to go to the ward, so a ward environment does not have your lovely 1 to 2, 1 to 3 nursing, and who are your eyes and ears for watching patient deterioration. If you send them out to the ward, I don't know how many of you have been admitted as a patient or have had a family member as a patient, it's very hard to find any staff. I'm sure they're there, but I just don't seem to find them easily. So you then think, well, gosh, there must be a system how we actually detect these patients. Should you send them out into the wilderness? So having been a ward registrar for some time, I do know what it's like. You feel very naked without all the monitoring system, and that you were sending them there. So if you want to think about it in a systematic way of seeing how you can pick up your patients who are going to deteriorate, you first of all make quite a lot of assumptions. And of course, assuming means making an ask of you and me. So I'm making an assumption that you're actually going to have someone document or perform and document vital signs. Because we've just said that probably blood pressure is quite important as a marker of unwellness, and particularly oxygen going to the tissues. So then you would like someone to not only perform a document, but you actually want someone to interpret your vital signs. So far, all fairly simple, you would think. And then once they've established that things are not quite right, you need the bedside nurse to then communicate, to actually have time to communicate and communicate meaningfully. And then you would like your probable doctor, junior doctor probably, to come to the patient and then review the patient and then actually interpret what needs to be interpreted, and again, then put timely and appropriate management in place. Now, these are all things that probably also could happen in the recovery area, but certainly in the ward area, you make these assumptions this is all going to happen. And hopefully the patient gets better or goes to a place where they might get more intense care. Now, the issue here, of course, is that there was the thought from Ken Hillman from Liverpool that maybe that system was not working very well, because you may have someone go and see the patient who's a junior doctor, but actually they don't know what to do. So instead of the sort of junior doctor from the ward environment going, let's do something differently and let's get someone who's skilled at critical care assessment and let's have them going straight from the intensive care unit out onto the ward area. And hence the medical emergency team. And I'm sure you're all very familiar with the criteria that we have for medical emergency teams. So this would make sense, that you'd bring the specialty team to a critically ill patient and get better, timely, appropriate decision making. So then there was a sort of plethora of studies of rapid response team review and cluster randomized control trials and many items in the literature of which there was no evidence to say that these medical emergency teams were actually doing any benefit at all. And of course, all this negative trials led to every single hospital in Australia having a medical emergency team. So that's how evidence-based we are. Now, that's not to say I've been slightly cheeky, because over the longitudinal studies, I think John Santamaria did one here, is that over 10 years they do seem to demonstrate benefit to the patient. But it is quite funny how we've just all ignored evidence and said this is the right, feels right, and we must do it. And I know certainly in Canberra, when I went very proudly saying that the MERIT study did not work, let's just get rid of the MET, there was like this, no, you can't, the wards won't be able to cope. So, as I say, there we are, evidence-based. So, because I was slightly cynical about the medical emergency team system at the time, so this is about 2004-05, I decided that maybe one of the problems that we face is, does the ward environment actually understand patient deterioration? So it's all very well having someone come in from intensive care to look at these patients, but actually, should this not be happening on the ward environment anyway? So we think about, well, what is that's needed and what will we be finding? So if you think about the whole circle again, what we need. So the first thing was, we think that they weren't recognising the patient deterioration, partly because the vital signs were not being performed, that we felt that the junior staff, both nursing and medical, were unable to recognise what was going on. They didn't have enough experience. We've talked about the number of doctors doubling over the last 10 years, so that must mean that they start to get less experience. And then, of course, the working hours have gone from 120 a week down to 40. So how do you expect your junior doctor to be experienced? And so this is an issue for us, certainly. And then when you think about communication, how many medical schools actually train doctors to speak to doctors? Increasingly so now, but certainly not back then. And I think that's another thing that we need to reflect upon. How do we structure communication to be meaningful? I mean, even in the operating environment or the recovery, I'm sure at the end you need a good structure to understand what your junior doctors are telling you. And then, of course, what we see, and sadly still see, is this so-called clinical cycle of futility that Michael Buis describes. You'll see lots and lots of activity, you'll see chest x-rays, ECGs, blood gases, everything, and yet no one is making the right decision at the right time because they do not have the experience. It's only when someone experienced comes in does something good happen. So you get inappropriate management and it's not timely. So if you like, it's not a very simple process and there's lots of things that need to be addressed. So certainly when we found that back in Canberra we were not even measuring respiratory rate that you would think would be done, which is the most sensitive and specific marker of patient deterioration, it wasn't being done. So that first assumption that we're measuring all the time was not true back then. So we thought, well, we've got to do something about improving the documentation, the interpretation, the communication, and the escalation response from the ward, as well as to the critical care environment. So it was going to have to be multi-pronged. And so we set about implementing change. And change is always hard when something's been done since Nightingale days. So that was a bit of a challenge. And so we set about a project. Our project involved ramping up education that, as the health minister said as we were about to launch this, well, surely this must happen in medical schools. Well, certainly patient deterioration didn't feature back then. We wanted to put a new observation chart that was human-factored, so it was better to interpret and put some track and trigger systems actually onto the observation chart itself. And then we were quite serious about how we were going to implement change. Couldn't just put out the new charts, wanted to make sure it's embedded by education and policies and guidelines. So there's actually quite a bit of work to get done prior to even starting the implementation of the observation chart. So our education program was Compass. It used to stand for something, but none of us could remember, but at least it's pointing you in the right direction. We weren't going to dictate what you need to do, because obviously it depended on the context and the patient at the time. But it was our education program, which has now actually been quite successful around the world. We also we were probably the first in the country to go to colour-coded charts. And as you can see, the one on the left is extremely unexciting. There were 3 variables on the same axis with different ratios, so it was virtually impossible to interpret. And then, of course, these days, we're now address the colour-blinded people and also try and put some guidelines on it as well. So what did we do? We did the education program, the guidelines, the new charts, and then implemented it into 4 ward areas. And over that time, 4 months, we measured and looked back to see the previous 4 months. And what we noticed that, in fact, we had changed behaviour. Finally, the respiratory rate was being recorded. Now, people argue, well, it's only 16 or 18. That's someone's lying, but at least it is being documented. So we have actually changed behaviour. Now, at that time, we did also change hospital mortality significantly. We reduced the number of intensive care admissions. And one thing that we didn't intend was that we thought we'd manage the patients on the ward environment by the ward doctors, but instead what's happened, it has exploded the number of MET calls. And so we were having to call MET back into the intensive care unit because our registrars are all out on the ward environment. So we went from 400 MET calls a year to 2,000 MET calls. So we've definitely changed behaviour and possibly even improved patient outcome. And now, of course, I sort of said to you, future steps. Well, I'm sure many of you now have a digital health system, and certainly back in Canberra, we was just in the midst of rolling out a digital recording of blood pressure, etc. Now, I think the challenge here, of course, is it's all very well to replicate your paper-based charts, which we've done very nicely. They look exactly the same, which is good from a human practice point of view. But we've not been smart about incorporating other risk factors, if you like, for patient deterioration and having a very sophisticated escalation process where it's much more attuned to the patient in front of you. And certainly there's some work done in Chicago where you're building in not only your digital observations directly from the blood pressure monitoring system, but also you're incorporating delta creatinines or other signs of organ failure so that, in fact, your escalation system is much more finely tuned and pick up your patients in neither a too sensitive or too specific matter. So it's actually a better system. So in summary, when you're going to implement these sorts of systems, you can't just do the clinical environment as only. You have to look at the organisational props that will help guide you and sustain what you want to implement. So the Australian Commission, when they were writing out their consensus statement for patient deterioration, said, yes, you need to look at your clinical processes and whichever environment that you're in. So it could easily be just in your ward environment as it could be in your post-anaesthetic recovery area. So you need to look at the fact that you've got the system in place to at least detect your patient and escalate accordingly. But you also need to make sure that you're monitoring what's happening. So gathering data is really important. You need to make sure that your staff are appropriately educated. Because remember, when we're looking at the 7-day week, where diseases operate 24/7, what do? We staff our organisation for 30% of the week, where we have everyone there, the senior decision makers, and 70% of the week is run by out of hours doctors who are mostly junior and inexperienced. So if we're going to make up for their inexperience, we have to make sure they get properly trained and educated. And so they've also suggested that we're now looking to technology to perhaps bypass some of the hierarchical issues that we find when junior doctors are too afraid to call their consultants, which unfortunately still happens today. So, in conclusion, I think we need to really work out, if we go right back to the beginning of your patient, is who is likely to benefit from the surgery and in the longer term. As we have not done very well in intensive care, we really haven't looked at the long-term outcomes, and I think we certainly need to do that more carefully, and whether we need to do that also in the surgical arena. I think we do need, once we've decided that we are doing surgery, we need to obviously ensure that they're safe. I think when you're looking at discharging a patient, as I say, to the wilderness, the so-called ward, we need to make sure that the discharge criteria are helpful. And if there's any doubt, it would be good to get someone senior to review the patient. And often what I see is that, yes, people are seeing the patient, but maybe still inexperienced, and also starting to tweak the escalation system. I always feel very nervous when people say, oh, the blood pressure's low because they've had an anaesthetic. The fact that they're bleeding or something else might be a small issue. And so I think we just need to be careful when we're going to tweak the triggers. Obviously, we do, once they're sent to the ward, we need ward systems which will capture these deteriorating patients. But it's not easy. There is a system that's quite complicated. But at the end of the day, whatever system you have to have the right person at the right time to make the right decision about these deteriorating patients. And again, I don't think we've quite got it right. And then I think the challenge we have is that we probably need to look at whole of system, yes, include technology, but it's only part of the solution because, sadly, I said about that 70% of the week is inexperienced junior doctors. They are still operating in a hierarchical environment where they are still sometimes afraid to call for help, and that help is senior and experienced. And on that positive note, I shall finish.
Nick Majerison here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We'll be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reid and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details, and while you're there, make sure you subscribe to Top Med Talk, and of course, you've joined us on social media. That's topmedtalk.com.